Hello students, I am Dr. Reethika Rathan, Assistant Professor from the Department of Oral Medicine and Radiology, Vinayak Mission Sankaracharya Dental College, Salem. Today, I will be presenting on the topic Oral Lichen planus, a chronic inflammatory mucocutaneous disorder of significant relevance in dental practice. Oral lichen planus affects 1 to 2% of the population, more commonly in middle-aged females, and is recognized by WHO as a potentially malignant disorder. So, oral lichen planus is a T-cell mediated chronic inflammatory disease affecting the oral mucosa. It was first described by the British physician Erasmus Wilson in 1869. The term lichen refers to the primitive plants made of symbiotic algae and fungi, and planus means flat. Oral lichen planus is not limited to the oral cavity alone. It can also involve skin, nails, hair, genital mucosa, gastrointestinal tract, and ocular tissues. A key diagnostic feature is its bilateral involvement, symmetrical presentation, and its chronic relapsing nature. The etiology is, although the exact cause of oral lichen planus remains unknown, it is considered as a multifactorial immune-mediated disease. The possible etiological factors includes genetic predisposition, microorganisms, allergy, stress. This is the main cause, and GIT disturbances, systemic diseases that includes diabetes mellitus, hypertension, etc., and occupational and lifestyle also affects the mucosa, and mucosal trauma, nutritional status also. The pathogenesis shows the interplay between antigen-specific and non-specific inflammatory mechanism in oral lichen planus. In this flowchart, first we will go with the antigen specific, where the cytotoxic CD8 cells with T cells trigger apoptosis of the basal layer of the epithelium. This in turn causes the response of cell-mediated immunity along with the keratinocytes antigen expression. This causes a migration of the T lymphocytes, which is activated by the antigen binding to the major histocompatibility complex on the keratinocytes or through the activated CD4 lymphocytes. Then it kills the basal keratinocytes through the tumor necrosing factor alpha. And in the non-specific inflammatory reaction, there is an aggravation of the T cell accumulation that in turn causes the basement membrane disruption that occurs by the mast cell proteases and keratinocyte apoptosis. This is the pathogenesis behind the oral lichen planus. The clinical features includes that it occurs mostly in 30 to 60 years of age and is commonly seen in women, and the most common site is the buccal mucosa, followed by gingiva, tongue, and mucobuccal folds. As I said before, the lesion usually occurs bilaterally and is often symmetrical, and sometimes it is associated with cutaneous lesions also. So in cutaneous lesion, what are the clinical features that can be seen are the rashes, which can be characterized by purple, polygonal, pruritic, and papules. These lesions measure 2 to 3 mm and often show Wickermann's striae, a lace-like white network. They commonly appears on the flexor surface of forearm and wrist. If there is scalp involvement, that may produce lichen planopilaris, resulting in scarring of alopecia. If there is nail changes, that includes longitudinal ridging, splinting, onycholysis, pterygium formation, and in severe cases, permanent nail loss. If the oral lichen planus occurs on the gingiva, it is most commonly present as a desquamative gingivitis. The gingiva appears as smooth, shiny, red, atrophic, and inflamed. The Wickermann's striae uncommon in gingiva, but sometimes may be present elsewhere in the oral mucosa also. So if there is plaque accumulation and associated inflammatory changes, it appears to aggravate the lichen planus only. Next, we come to the clinical types. There are reticular form, papular form, plaque form, bullous form, erythematous or atrophic form, and ulcerative form. The oral lichen planus appears in multiple clinical forms. The first and foremost is the reticular form, that is the most common interlacing white striae appearance is noted. As you see in the image, you can see the white striations. So this is called as the Bickerman striae. So it is mostly asymptomatic and may coalesce into reticular pattern. Next is the papular form, which appears as a pinpoint white papules, and later on, due to coalescing nature, it forms as a reticular pattern. This also is asymptomatic. Next is the plaque form. This resembles like leukoplakia only. So, and how to differentiate is the common smokers, and mostly it occurs in the dorsum of the tongue or buccal mucosa. Next is the bullous form. Bullous form is painful and causes the discomfort while eating spicy foods. So usually it appears as a blister and then it is followed to rupture that causes the erosive nature. So next is the erythematous and atrophic form. So here there is erythema with thinning of the mucosa, and it is also noted mostly in the gingival area. So there is desquamative gingivitis appearance noted. So here there is profuse bleeding, and sometimes it is surrounded by Bickerman striae also. So the last form is the ulcerative form. The ulcerative form is most severe form and painful, surrounded by white striae, and mostly it is associated with bleeding. These are the clinical types of Lichen planus. Now we come to the differential diagnosis of Lichen planus. The first diagnosis is the lichenoid reaction, then lupus erythematosus, leukoplakia, keratosis, malignancy, chronic ulcerative stomatitis, graft versus host disease, pemphigus, pemphigoid. So the oral Lichen planus must be distinguished from several similar appearing lesions. So first we will go with the lichenoid reaction. Lichenoid reaction closely resembles oral Lichen planus both clinically and microscopically. They are usually caused by dental materials like amalgam, composites or alloys, and sometimes medications like NSAIDs, antimalarials, antihypertensive drugs. The key difference to differentiate from oral Lichen planus is they are usually unilateral and located adjacent to the causative drug or restorations. The removal often resolves the lesion. Next is the lupus erythematosus. Oral lesion in lupus may mimic the reticular pattern of oral Lichen planus. The key distinguishing factor is that the central erythema with peripheral keratotic streaks. The lupus erythematosus also shows positive anti-nuclear antibody and other autoimmune markers. Even in histology, it shows thickened basement membrane and positive PAS. And next is the leukoplakia. Leukoplakia is a potentially malignant white patch. The differentiating factor is that it usually occurs unilateral, homogeneous white patch without Bickerman striae, and it does not have the symmetrical presentation as you see in oral Lichen planus. And the next is the keratosis. The keratosis refers to benign keratinized lesion such as frictional keratosis. So the differentiating factor is that it is usually caused by a chronic mechanical irritation and has clear traumatic source, does not show the band like lymphocytic infiltration as you see in the oral Lichen planus. Next is the malignancy. So the advanced erosive or ulcerative lesion may resemble early carcinoma. Differentiating factor includes the induration, non-healing ulcer, and rolled out or raised borders are noted in the ulcer, and histopathology confirms the diagnosis. Oral Lichen planus ulcers are usually shallow and inflammatory that differentiates from malignancy. So the chronic ulcerative stomatitis is a rare autoimmune condition presenting with chronic oral ulcers that resembles mostly like erosive Lichen planus. So to differentiate, it is mostly persistent painful erosion, and the direct immunofluorescence shows the confirmatory like anti-DSG3 IgG autoantibodies, and it also does not respond well to the corticosteroids like oral lichen planus. So that is the differentiating factor. Whereas graft versus host disease is seen in patient after transplant. So the differentiating factor is that there is reticular or erosive white lesion, and mucosal sensitivity and ulceration is also noted on palpation, and to differentiate is by the clear history whether there is any transplantation done, and you can also see association of skin rashes, liver dysfunction and systemic symptoms in graft versus host disease. So then is the pemphigus and pemphigoid. Both are autoimmune blistering disorder and can mimic erosive oral lichen planus. So in case of pemphigus vulgaris, there is intraepithelial blister and it shows positive Nikolsky sign, and in immunofluorescence test you can see a fishnet pattern, and that is the differentiation factor for that. And whereas in mucous membrane pemphigoid there is subepithelial blisters, and seen commonly as a desquamative gingivitis is also seen in mucous membrane pemphigoid, and linear deposition on the basement membrane in immunofluorescence tests. So all these differential diagnoses can be confirmed through history, examination and biopsy. So next we go with the investigation. So the first investigation is biopsy. Biopsy is the gold standard for confirming oral lichen planus. So the histopathology shows why the biopsy is used is because the importance is in erosive or non-healing cases. It is used to rule out dysplasia. So that kind of condition you can go about with biopsy. So in biopsy you can see hyperkeratosis of surface epithelium, sawtooth retiridges, thickening of the granular layer, acanthosis of spinous layer, intercellular edema in spinous layer, liquefaction necrosis of the basal layer, juxtaepithelial band of inflammatory cells, predominantly T lymphocytes, cavate or hyaline or cytoid or colloid bodies, eosinophilic bands are also seen in biopsy histopathology. Next we go to the patch test. When a lichenoid reaction is suspected due to amalgam, restoration or denture materials, a patch test may be done. The lichenoid reaction caused by contact materials are usually unilateral, unlike oral lichen planus which is bilateral. If positive, relapsing the restoration often leads to resolution. Next is the immunofluorescence. Direct immunofluorescence helps differentiate oral lichen planus from other vesiculobullous diseases. So the first in oral lichen planus you can see a shaggy fibrinogen deposition at the basement membrane. As you see here, this is the appearance seen in the oral lichen planus. As you see, there is a shaggy appearance of fibrinogen. So the next is the mucous membrane pemphigoid. You can see a smooth linear band. As you see here, you can see a smooth linear band in the basement membrane. So next is the pemphigus vulgaris, where you can see a fishnet intercellular pattern. So next is the erythema multiforme. You can see a perivascular pattern within the deeper connective tissue. This test is highly useful in doubtful cases. Next, we'll go to the malignant potential of oral lichen planus. In 2005, the WHO classified oral lichen planus as the potentially malignant disorder. The transformation rate is 0.5 to 2%, with the erosive and atrophic form posing the greatest risk. The risk increases with tobacco use, alcohol, chronic irritation, poor oral hygiene, and long-standing lesions. Thus, the patient require long-term follow-up. Next, we'll see the syndromes associated with oral lichen planus. The syndromes are Greenspan syndrome, vulvovaginal gingival syndrome, Pinot-gingival syndrome, Graham-Little syndrome. So first we'll see the Greenspan syndrome. The Greenspan syndrome consists of a triad of diabetes mellitus, hypertension, and oral lichen planus. Next we go with the vulvovaginal gingival syndrome. This syndrome presents with lichen planus lesion simultaneously involving the vulva, vagina and gingiva. The patient typically have painful erosions, burning sensation, pain during having any spicy foods, and if in case there is desquamative gingivitis also can be noted. It is considered a several mucosal variant of erosive lichen planus requiring combined management by the dermatologist and gynecologist and also dentist. The next is the pinogingival syndrome. Here you can see the involvement of oral lichen planus in the pineal mucosa and gingiva. Usually it appears as a red, erosive or ulcerative lesion in the pineal mucosa, and it also causes burning or soreness in the oral mucosa, and it is also associated with desquamative gingivitis. This syndrome highlights that lichen planus can involve multiple mucosal sites simultaneously. The last is the Graham-Little syndrome. It is also known as Graham-Little Picardy-Lachey syndrome. This is a rare variant of lichen planus characterized by a triad like scarring alopecia of the scalp and non-scarring hair loss in the axial or groin, keratosis pilaris like follicular papules on the trunks or limbs. It represents as a severe follicular form of lichen planus, and the scalp lesion may resemble lichen planipilaris leading to permanent hair loss. Next, we go to the management. So, the first line treatment is with the corticosteroids. The topical steroids used are 0.1% triamcinolone acetonide, 0.025% clobetasol propionate, 0.05% fluocinonide, and the systemic prednisolone is reserved for severe or widespread cases, and intralesional injection helps in the persistent localized lesion. And next is the calcineurin inhibitors. In calcineurin inhibitors, there are drugs like cyclosporin, pimecrolimus, tacrolimus. These are immunomodulator drugs that suppresses the T cell activation, which is the main mechanism behind oral lichen planus. First, we'll go with cyclosporin. Here it inhibits the T cell activation and decreases inflammation. It is often used in topical form for erosive lichen planus. Next is the pimecrolimus. It is a topical immunomodulator with a fewer side effects than steroid. It is useful for long-term maintenance therapy. Next is the tacrolimus. It is one of the most effective topical agent for steroid-resistant oral lichen planus. It helps to reduce pain, burning and ulceration, and it acts by binding to the calcineurin and blocks the T cell activation. Overall, the calcineurin inhibitors are excellent alternative when steroids are resistant or cannot be used. Next, we go with the retinoids. In retinoids, the retinoids are vitamin A derivatives that regulate epithelial growth and modify the immune response. The drugs are tretinoin, isotretinoin, ferriretinide. So first we'll go with the tretinoin. The topical retinoid used in keratotic or plaque-like oral lichen planus. It helps to reduce the hyperkeratosis. And next is the isotretinoin. It is used systemically or topically in resistant cases. It helps to reduce the inflammation and epithelial turnover. Last is the fenretinide, a systemic retinoid with chemopreventive potential. So sometimes used in managing the pre-malignant features. So basically the retinoids help normalize the epithelial changes and reduce keratinization in oral lichen planus. Next we go with the herbal modalities. The herbal modalities are natural agents that have anti-inflammatory, antioxidants and immunomodulator properties. They are also have fewer side effects. So the herbal products are curcumin, aloe vera gel, tulsi and black pepper. The curcumin is a form of turmeric and it has a strong anti-inflammatory and antioxidant activity. It reduces the burning sensation and ulceration. Next is the aloe vera gel. It soothes the oral mucosa, promotes the healing of erosion and reduces the pain. Next is the tulasi. It has an anti-inflammatory and antimicrobial property that causes the benefit in mild oral lichen planus cases. The last is the black pepper. It contains piperin, which enhances the absorption of curcumin, and it has an anti-inflammatory effect. So the overall benefit of herbal modalities is that it has a supportive therapy that helps to reduce the symptoms and improve healing. Next is the antioxidant, that is the lycopene, a strong antioxidant found in tomatoes. It reduces the oxidative stress which is elevated in oral lichen planus, and it's shown to improve symptoms and reduce the erythema and burning. The benefit of it is that it neutralizes the free radicals and help reduce chronic inflammation. The last is the topical anti-inflammatory drug, amlasanox. It is a topical anti-inflammatory and anti-allergic medication that reduces ulceration and provides symptomatic relief. Useful in patients who cannot tolerate steroids. So the overall benefit is that it reduces the inflammatory mediators and helps in healing minor erosions. Next, we go to the photodynamic therapy. The photodynamic therapy uses methylene blue activated by a specific wavelength of laser light to produce free radicals that destroy inflammatory cells. It is minimally invasive and avoids steroid-related side effects, and some temporary erythema or desquamation may occur. Next, we go with the PUA therapy. It combines 8-methoxysorolin with ultraviolet A light. The sorolin binds to the DNA and reduces the mitosis and immune activity when activated by UV. Although the effective PUA therapy may cause nausea or dizziness and is used selectively. Next is the low-level laser therapy. The low-level lasers are like helium, neon, ruby or argon lasers work through photobiomodulation. They reduce the inflammatory mediators and improve the microcirculation and modulate the mast cells and promote healing. This in turn reduces the pain and burning sensation which is caused by the oral lichen planus. The low-level laser therapy is safe, painless and useful in steroid-resistant cases. This is a flow chart which shows the systematic operating protocol of oral lichen planus. When a patient reports to the department with a burning sensation, if the patient gives history of any habits like betel nut chewing, or any stress history or any past dental history like restorations and past medical history with drugs like diabetes mellitus, hypertension or etc., and genetic like autoimmune conditions and viral etiologies, bacterial etiologies, fungal etiologies and any food allergies. And in case if the patient only presents with the clinical features, like if you notice any papules with the clinical types of oral lichen planus that involves a reticular type, bullous type, erosive type or any form of clinical types, and if in case there is association of cutaneous manifestation, you can see any pruritic rashes, hair loss or nail involvement, those kind of cases, if the patient history and clinical findings are noted to be positive, then the following provisional diagnosis can be given. So if in case of an oral lichenoid reaction, then removal of causative factors, follow up after 7 days is needed, and if it is healed, the follow up after 1 month is required. Whereas if the lesion is not healed, then you can give a diagnosis of oral lichen planus and follow the protocol. So if the patient is contraindicated to the steroids, then you can go with the drug of dapsone 100 mg OD for 3 months, and the patient has to be evaluated for every 15 days up to 3 months. And in case a patient is not allergic to any steroids and does not have any resistance, then you can go about with the biopsy and then followed by the conservative treatment, that is the topical application, along with if there is any traces of fungal involvement, then you can give the topical antifungal agents. So if in case the symptoms subsides, then the follow-ups of 7 days and follow-up of after 1 month can be done. And if in case the lesion does not subside, then you go about with the systemic treatment. Systemic steroids can be given along with topical application and along with the antifungal drugs. And if in case the symptom subsides, follow-up after 7 days and follow-up after 1 month is required. If the lesion still persists and does not relieve on symptoms, then recalcitrant oral lichen planus can be done. The treatment protocol is that intralesional steroids can be given 1 time per week for 4 weeks, and immunomodulators can be given, immunosuppressions can be given, and antifungal agents can be advised. So latest treatment modality for this kind of oral lichen planus is PUA therapy, and newer drugs like mycophenolate, mofetyl 500 mg, stracolimus, famicrolimus can also be given. So long-term effect of these drugs are not known as they are still in trial. Thus, I conclude by saying that a chronic inflammatory condition driven by cell-mediated immunity and presenting in several clinical forms from asymptomatic reticular pattern to painful erosive lesion. Because many disorders closely resemble oral lichen planus, that accurate diagnosis through clinical features, biopsy and immunofluorescence is essential. Its classification as a potentially malignant disorder highlights the importance of early recognition, appropriate therapy, patient education and regular long-term follow-up to prevent complication and ensure better outcomes. Thank you.